Thank you very much. And first of all, let me also thank the organizers of this Congress, Mohamed, Arnon, Thierry. Thank you very much for this invitation. And so what I will do in the following 25 minutes is discuss with you indeed the role of proteasome inhibitors in the relapsed setting. And just to start with a brief journey through time, just to remind you, currently we're speaking about 3 proteasome inhibitors: Bortezomib, Carfilzomib, ixazomib. And above you see the registration in EU compared to at the lower part of the study in the US. And just to remind you that Bortezomib was approved for relapsed myeloma in 2003 in the US, followed in 2005 by an approval for second line and 2008 for frontline treatment. Whereas in Europe, 2004 approved for third line, 2008 approved for frontline treatment for elderly patients in combination with MP, the so-called VMP regimen, and 2013 registration for upfront treatment in transplant candidates. For Carfilzomib, it was already approved 4 years ago in the United States as a single agent for relapsed patients, and early 2016 in combination with dexamethasone, KD, and KRD. Whereas in Europe, end of 2015, it approved a positive CHMP opinion for KRD. And regarding ixazomib, in November 2015, approved by FDA for IXA-RD, and in end of 2015, the EMA accepted the marketing authorization approval for ixazomib. Now, the role of proteasome inhibitors in multiple myeloma is especially thanks to the contribution of these 3 excellent scientists who discovered the mechanism of the ubiquitin-mediated protein degradation, and they were awarded the Nobel Prize Chemistry in 2004. Now, just to remind you, what are proteasomes? Proteasomes, they are multi-catalytic enzyme complexes, and they are present in every eukaryotic cell, both in the cytoplasm and in the nucleus. And they are hollow cylinders with, at the end you have in the 20S proteasome, the 90S cap, and the central catalytic 20S core, which exerts the enzymatic function. Now, how does a proteasome function? Well, in brief, it is critical in protein homeostasis. In other words, proteins are recycled through the proteasome and misfolded proteins are destroyed by the proteasome. And it is obvious, and we have seen the clinical evidence for many years, that protein-producing plasma cells, they are highly depending on a normal functioning of their proteasomes. But in order to avoid that, normal proteins are destroyed. The proteins to be degraded by the proteasome, they are tagged by ubiquitination. And these ubiquitinated proteins, they are recognized by the 90S cap, they are unfolded, they get through the proteasome, and they are cut into pieces by the proteolytic caspase, trypsin, and chymotrypsin domains of the catalytic core. Now, as you know, the role of proteasomes, and especially proteasome inhibitors, in myeloma, and more precisely on plasma cells, is quite complex. Initially, there was an important role contributed to NF-kappa B signaling, but as we know, there are many other ways why proteasome inhibitors interfere with the survival of plasma cells, with their proliferation, with their cell adhesion, and cell spreading. Now, this slide tries to summarize the proteasome inhibitors that we are currently using in clinical daily practice, and those in several phases of clinical development. And here, of course, you have the first-in-class bortezomib, which is a boronic acid, which is a reversible inhibitor of the chymotrypsin or beta-5 catalytic unit, together with caspase inhibition activity, which is beta-1 catalytic unit. And then, of course, we have the oral boronic acid, ixazomib. However, it is not me-too bortezomib. It has structural and functional differences. But the major advantage is that it can be given orally. And then there's the third one, delanzomib, but the question is if this drug will ever come to the market. Then the second class are the epoxy ketone proteasome inhibitors, primarily targeting the beta-5 chymotrypsin unit and in a more irreversible way. We have the IV form, Carfilzomib, and we have an oral form in preclinical testing, which is called oprozomib. And then finally, we have a third class, which is salinospor, which is marizomib, targeting the 3 catalytic units in an irreversible way. And very recently, some interesting phase 1/2 data have been released in Blood with Paul Richardson as the first author. But it is not without any reason that we call proteasome inhibitors a backbone of myeloma treatment. And this is primarily due to bortezomib. And let me just take you briefly to the most important studies that have been conducted with bortezomib in relapsed and relapsed refractory myeloma. And again, we go back in time, and we end up in 2003 with the phase 2 study, the so-called SUMMIT study, published by Paul Richardson in the New England Journal of Medicine, and proving that bortezomib as a single agent could induce PR or better in 1 out of 3 relapsed refractory myeloma patients. And briefly after, there was the phase 3 randomized study, the so-called APEX study, comparing bortezomib again as a single agent with high-dose dexamethasone. And the most important conclusion from that study was that bortezomib was significantly better, not only in terms of response, but also in terms of time to progression compared to the comparative arm. Now, therefore, another way of showing you why bortezomib is not a coat hanger, but it's a backbone to add on other drugs or other classes of drugs. And the first drug is steroids, dexamethasone. And we use currently bortezomib in combination with dexamethasone. But let me remind you, there is no single study that has compared in a prospective way bortezomib single agent with bortezomib plus dexamethasone. But the evidence of the beneficial use of this combination comes from preclinical data, but also a retrospective analysis of many clinical studies. And here is a summary of some of these studies showing that the combination of bortezomib plus dexamethasone in the relapse setting was significantly superior in terms of response, in terms of progression-free survival, time to progression, compared to bortezomib as a single agent. The second class of drugs that we combine bortezomib with is chemotherapy. And again, supported by many preclinical data, but clearly shown also validation clinical trials. And we don't have time to go through all the different studies, but many of these data are based on interesting phase 2 data. But an important phase 3 study was a comparison of bortezomib single agent with bortezomib plus pegylated liposomal doxorubicin. And this study, published by Bob Orlovsky in 2007, clearly showed that bortezomib plus pegylated liposomal doxorubicin induced significantly better and also significantly longer responses compared to bortezomib as a single agent. Third class of agents that we can hook up to bortezomib is the class of the IMiDs. And again, many phase 2 studies showing the benefit of adding lenalidomide, dexamethasone, pomalidomide, dexamethasone. But I just want to show you this phase 3 study from Laurent Garderet, who has compared TD with VTD. and where the median time to progression was around 14 months in the TD arm, it was significantly prolonged to 19 months in the VTD arm. However, the combination of VTD and especially a prolonged exposure to this combination in patients with the first relapse after autologous transplantation was associated with significantly high-grade peripheral neuropathy. So, shortly thereafter, we have learned that changing the administration regimen of bortezomib could really improve its tolerance and especially could reduce the neuropathy. And first of all, this can be obtained by prolonging the interval between the injections from 3 days to 1 week, but most importantly by changing the administration route from IV to sub-Q, which should be the current way that we give bortezomib, because it results in equal efficacy but significantly better tolerability and more precisely significantly lower grades of severe peripheral neuropathy. Fourth class we can add to bortezomib are the HDAC inhibitors. We know about the study of the combination of bortezomib with borinostat, but I just want to share with you the data of the combo with panobinostat and data from the Panorama study that clearly showed, again, a significant progression-free survival that was increased from 8 months in the bortezomib-dexamethasone arm to 12 months in the bortezomib-panobinostat-dexamethasone arm. But again, in this study, patients received bortezomib intravenously, and there was some significant increase in toxicity, more particularly in GI toxicity in the experimental arm. And finally, bortezomib is also a very good backbone to add up monoclonal antibodies like elotuzumab and daratumumab, and very shortly at the next EHA meeting we will hear some interesting data on those combinations. So, without any doubt, bortezomib has changed the way we treat myeloma patients. And during the years, bortezomib has gradually moved from late relapse to early relapse to upfront treatment. And the good news is, what I have shown you is that we can combine it with many different classes of active anti-myeloma agents, improving the efficacy, but also without excess toxicity. So, building further on this concept of proteasome backbone, newer classes of proteasome inhibitors entered clinical practice. And I will share with you the data in the relapse setting with carfilzomib and ixazomib as the proteasome-based backbone. And of course, I know many of you have seen the slides already maybe too many times, but again, this study is very important, this Endeavor study, because it compares head-to-head the combination bortezomib-dexamethasone with carfilzomib-dexamethasone. Just to remind you that in this study, carfilzomib was after an initial starting phase of 20 milligrams square meter, only on days 1 and 2 of cycle 1, the dose was increased to 56 milligrams per square meter. This Endeavor study included nearly 1,000 patients and patients with 1 to 3 prior lines of treatment, and it compared KD with the standard VD regimen, where 20% of the patients received the bortezomib intravenously and 80% received bortezomib sub-Q. Now, in terms of progression-free survival, it was clearly shown that KD was significantly superior to VD, with a mean progression-free survival or median progression-free survival of 18.7 months in the KD arm compared to 9.4 months in the VD arm. So KD doubled PFS compared to VD, with an hazard ratio, as you can see, of 0.53. Now, in terms of proteasome inhibitory activity, here we see the in vivo confirmation of the in vitro data that KD is much more potent than VD. The overall response rates were 77% for KD compared to 63% for VD, and also significantly higher levels of VGPR and CR, which nearly doubled compared to VD, with the median follow-up in this study was around 1 year. But importantly, the question is, what about efficacy of KD in patients who have been exposed previously to bortezomib, which is the majority of the myeloma population, at least in Europe? So I need to remind you that this study did not allow for inclusion of patients who were refractory to bortezomib. But nevertheless, the half of the patients were priorly exposed to bortezomib. And as you can see here, KD remained superior to VD in patients previously exposed to bortezomib. Now, KD in the relapse setting seems to be significantly more effective compared to VD, but the question is, what about the tolerability? And of course, our first concern is peripheral neuropathy, because this is the most important side effect of bortezomib. But as you can see on this slide, the peripheral neuropathy, that was 32%, and PN was defined as grade 2 or higher, 32% in the VD arm, it was only 6% in the KD arm. So in other words, significantly lower, and serious peripheral neuropathy is no issue with carfilzomib. But what about other, maybe new side effects? And whereas we had a green light for peripheral neuropathy, we get a kind of a warning signal for some new side effects, more precisely in the cardiovascular setting. So, as many of you know, some patients receiving KD developed hypertension, and a small fraction of patients were at risk for developing cardiac failure. So, reduction of peripheral neuropathy, but on the other hand, a warning sign for some new side effects. So, since bortezomib is an ideal target drug to combine with other effective anti-myeloma agents, the question is this the same for carfilzomib? And again, we don't have time to go through all the data, but let me just share with you the most important study, which is the ASPIRE study, that has compared RD with RD plus carfilzomib. But again, the way how carfilzomib was given is a little bit different from the ENDEAVOR study where KD only was used. So with KRD, here you see the doses of carfilzomib were lower, 27 milligrams per square meter, although the administration regimen was the same during the first year. That means intravenous infusion on day 1, 2, 8, 9, 15, 16 in a 28-day cycle. But from month 13 to month 18, the carfilzomib was only given on day 1 and 2 and day 15 and 16, and after 18 months of treatment, patients continued with RD only. Now, let's look at the results of this study. The median follow-up in this study, if I remember well, it was around 32 months. Median progression-free survival was 26 months in the KRD arm and 17.6 months in the RD arm. So a net benefit of 9 months in median progression-free survival. But as you can see here, after 1.5 years, the curves tend to come closer to each other, which could be related to the fact that the carfilzomib was discontinued after 18 months of treatment. In terms of pure anti-tumor activity, expressed here as the different levels of response, KRD induced a CR rate of 31%, which is unprecedented in relapsed refractory myeloma setting, and which was also significantly better compared to the RD arm. So again, this table summarizes the efficacy in terms of median progression-free survival and duration of response, and also in both arms there was a very rapid response, and of course this is associated with symptom reductions for patients. Now, as for many other drugs, the earlier we use them, the better the results. And the same is true for the KRD regimen. If it was given at first relapse compared to second or third relapse, the median progression-free survival was longer, 29.6 months compared to 25.8 months. Now finally, there is the third in class, or the third proteasome inhibitor called ixazomib, which is, again, to remind you, a boronic acid derivative, but which has the advantage of being given orally. And as already alluded to, this study was published in this week's issue of the New England Journal of Medicine with Philippe Moreau as the first author, comparing RD plus placebo with RD plus ixazomib in patients having received 1 to 3 prior lines of anti-myeloma treatment. And the major endpoint, or the primary endpoint of this study, was also progression-free survival, and this was significantly longer in the IXA-RD group compared to RD, with a median PFS in the control arm of 14.7 months and 20.6 months in the experimental arm, with an hazard ratio of 0.74. But again, maybe here the curves look a little bit different. Initially, they are more or less superimposable, and then after more than half a year, they start to separate, which is a quite interesting observation. So also as for the other studies, for Endeavour and Aspire, many subgroup analyses have been done, and they more or less show the same, that the triplet is superior to the doublet for the different subgroups according to patient characteristics like age, according to disease characteristics like ISS stage, like cytogenetics, numbers of prior treatment lines. But maybe just to pinpoint, and for this combination, that especially in patients with high-risk cytogenetics, that the IXA-RD, or the addition of ixazomib, seemed to abrogate the negative impact of high-risk cytogenetics, which is quite an interesting observation. Now, what about the most important side effects? So the combination of IXA-RD induced a little bit more thrombocytopenia and also some more moderate skin rash. On the contrary, there was no sign of cardiovascular toxicities like increased rates of hypertension or cardiac failure. Now, what about the future? What about maybe potential treatments for patients who are refractory to these different proteasome inhibitors? Well, we have to wait. As already mentioned, maybe delanzomib will not make it to the market. Oprozomib is still questionable, but some recent interesting results with marizomib. So this brings me to my conclusion, and I hope I have shown you that proteasome inhibitors, and particularly bortezomib, has dramatically improved the outcome for patients with multiple myeloma. And bortezomib-based regimens, they have paved the path, but they have gradually moved now from a relapse setting to frontline treatment. In the relapse setting, and this has been clearly shown by Xavier Leleu, lenalidomide dexamethasone has become now a very important backbone where we can hook up monoclonal antibodies, but also, maybe as importantly, second-generation proteasome inhibitors like ixazomib and carfilzomib. But this congress is called Controversies in Myeloma, so therefore I thought maybe to end up with a slide with some controversies, because we have now very active triplet combinations in relapsed myeloma, and they all have been proven to be very active. Now, one of the challenges for us will be in the following years, when we have access to all these different combinations, how to make the choice. And will this be based primarily only on pure efficacy like PFS and overall response rate, or will we have what I would call to fine-tune according to some specific characteristics, like patient-related characteristics, age, high-risk cytogenetics? What about differences in side effect profile? What about compliance, IV versus oral? So these are all different questions that we should try to answer. And I would like to end not without comparing highly active anti-myeloma drugs with wine. That should be, from my point of view, at least very offensive towards patients. But I just want to show you, because it's about the dilemma of choice. And so we are in France. France is still one of the most important wine countries, and according to their president, it's maybe the country with the most expensive wines. So therefore, I show you 2 bottles of very expensive red wine. And maybe after this Congress, if you want to hang around in Paris and you think it's time to digest all these clinical and preclinical data, and I want to do it with a good glass of very expensive red wine, this could bring you to a dilemma. And therefore, maybe to solve this dilemma, you could go for this typical Belgian beer, which is brewed at the place where I live. It calls Grimbergen. But I would definitely discourage you to go for the triplet, because in that case you might end up with some unforeseen and unpleasant side effects. And with this I would like to close and thank you for your attention.